Ladies and gentlemen, I really have to congratulate the local organizers here and the scientific committee to get such a wonderful meeting put together. And I think this is the largest turnout in about a decade of ESA lectures. And I would like to have my first slide, please. Gentleman who was laughing in the back. Yes, may I have my first slide, please? Thank you. Yeah, so in the beginning there was nothing, you see? And then God created the world and a helpful technician. And there we have our ESA lecturer of this year. And I'm very proud to be the introducer of Seyhan Ozkan. And her husband Ilhan was very gentle and sent me secretly some pictures. So let me take you by the hand and walk you through the life of Seyhan. These are childhood pictures. You see her with her parents, her older sister, and her grandparents. And note that the whole family is looking straight ahead, except Granddaddy and Seyhan. And that already mentioned at an early age that she was scanning the world. What is happening, not only with that camera, but what is happening on the side. Her childhood, as a matter of fact, she was born in 1963. Sorry, Seyhan, Ilhan told me. She was the second daughter of the cultural attaché of the Turkish embassy. Her father was a history lecturer at the university in Turkey, and her mother was a mathematics teacher. So if you combine mathematics with history, that's what you get. She always had one older sister, which is always very handy. I had an older sister too, because then the parents already have some experience, and then you can take advantage of that. It's like it's through the jungle, there is already a path cut. And she was always the youngest student in her class in Ankara. So that means that the challenge is always a little bit higher because you're lagging, missing 10 months, because you're a young student. As a first-year medical student, she suffered Stevens-Johnson syndrome, so she learned ophthalmology as a patient, not as a student. And that really pushed her into ophthalmology. Another anecdote is that it took Ilhan 9 years of friendship to have the wisdom to date Seyhan. But on the other hand, he could think about it 9 years, and they married in 1986, 1 year after graduation. Ophthalmology. She did a residency in 1986 till 1990 in Turkey, in a Numune hospital. And then she did a life and career-changing fellowship in the Moorfields Eye Hospital in London with the late John Lee and Peter Phelps. Also had side trips to the Great Ormond Street Hospital for Sick Children in London. Then after that, because Ilhan was doing a fellowship in Osaka in orthopedic surgery, she followed him and spent another couple of months in Japan, where she picked up the Oriental perspective of ophthalmology. And then they moved in 1993 to Aydin, where she climbed the ladder of academics and became a full professor in 2002. These were the London years, which really boost her career. You see her with her big friend John Lee, who unfortunately passed away 2 weeks after the ESA meeting in Istanbul, which was organized by Seyhan. And Peter Phelps, you see them at the cocktail party in 1998 at the ESA meeting, which was organized by my wife and me. And in that order, otherwise I get in trouble at home. This shows actually the core of her family. Seyhan and Ilhan, and their daughter Kansu and son Khan. Isn't that pretty? That's so cute. But she's not afraid to climb up the hill. So the uphill battle, that's nothing new for her. She really needs challenges. And you see, she's already sitting down when the others are still climbing up the hill. So she's a front runner. ESA and ESA, we first met in 1992. That's today, that's 25 years ago, Seyhan. 25 years ago. And she was very active and still is very active in the ESA. She organized the ESA 2004 meeting in Izmir, became after that ESA president from 2004 to 2009. And some people only be a local organizer, including me, for one event, because that's a once-in-a-lifetime experience. You're never going to repeat that. But lo and behold, 6 years later, Seyhan organized the wonderful meeting in Istanbul of the ESA. And she is president of the ESA since 2014. And I think you're the only one, at least the only woman who had held presidencies from both European and world organizations. And that's something which is outstanding and remarkable. And you're doing an excellent job. Just a little flashback. This is the Izmir meeting, which was wonderful because it was not only in Izmir, but also we had an afternoon trip and dinner in Ephesus. And here Günther von Norden had a lecture in this old amphitheater about the history of strabismology. And one of the things was that we had to wait 45 minutes for the sun to go down in order to have enough darkness so he could present his slides. And this was something phenomenal. We had a dinner at the Celsius library, a place where you normally cannot get in. Let's have a dinner and a party. But Seyhan organized that. How? I don't know. 25 years of friendship. Look at me. Look at me. And look at Seyhan. I mean, we both grew, had more experience. I aged 25 years, but Seyhan? No, she looks the same. I don't know how you do that, but there must be a secret to that. And then science. She had 119 peer-reviewed publications, 5 book chapters, editor of True Transactions book of the ESA, 130 invited international talks, 56 national talks. I mean, you could open your own talk show. But angles need to be cured. Her goal is ortho, either orthodox, with surgery, or ortho Botox. And that will be her title this in a few minutes. And she married an orthopedic surgeon. So how ortho can you be? But all in all, it's in the hands of either the surgeon or somebody who is standing behind you. Yeah? I think in Arabic you say inshallah. But sometimes it's in the hand of God, or sometimes if God makes a mistake, then the surgeon has to correct it. That's another way of seeing it. But I And now I will present my last slide. I would like to invite the angel of angles to the podium and give her ESA lecture. Seyhan, please.
Mr. President, dear colleagues, ladies and gentlemen, I've been greatly honored for being elected as the ESA lecturer of this year, and I would like to express my sincere thanks to the ESA Council for this great honor. And with many, many thanks for my dear friend Jan-Geert de Faber for this very joyful presentation, and also he made me so spoiled. Thank you so much. I'm so proud that I have such a friend. Thank you. So now I need to find my presentation. My topic for today is going to be on the use of botulinum toxin. Yes, here we are. So I'd like to dedicate this lecture in memory of my mentor, John Lee, and who was a pioneer of botulinum toxin treatment and who taught me how to use this agent. I have no financial interest to disclose. And during this lecture, we will go through the answer of the questions: is it only an alternative treatment in strabismus, or does it have any plus value and plus indications where surgery cannot be the solution? So I'm going to talk briefly about the historical perspective, mechanisms of effect, injection technique, and current indications. And during this current indications, I'm going to present some case examples where I find the botulinum toxin use most helpful during the 25 years of experience by using this agent. And then complications and then conclusions. If we look at the historical perspective, Konrad Behrens was the first to consider about pharmacological treatment of strabismus. He tried some agents, but he had been unsuccessful. But then Alan Scott experimented various drugs, and he found that botulinum toxin can be used for this purpose, and he made a huge contribution, and he made many studies on that, and we owe this treatment to his studies. And the human studies with toxin started at 1977, and then FDA approval was got at 1989 for adults and children over 12 years of age. However, this indication is still there. It is still approved for children over 12 years of age, which is a great problem. So I'm not going to talk a lot about the pharmacological aspects. There are 8 antigenic types, and type A is used for strabismus treatment. It interferes with calcium metabolism, blocks acetylcholine release, and produces a chemodenervation effect. And the maximum effect is reached on 7 days, and the paralytic effect lasts around 2 months. Toxin effect overall lasts around 6 to 9 months, and the relative contracture of the antagonist extraocular muscle develops during this time. There are 3 basic types of toxin in the market as Botox, onabotulinum toxin, Dysport, abobotulinum toxin, Xeomin as incobotulinum toxin. As this is a biological product, their names are different. So what happens when we inject botulinum toxin into the extraocular muscle? Well, in this child, a left medial rectus injection is performed. As you see here, there's an overcorrected period, there's an exodeviation here, there's a limitation of adduction here. Is the mouse seen over the screen? Oh, no, so I'm not going to do that. Anyway, and then 2 months after injection, the motility is on the normal side, but the deviation is corrected. And this period, this paralytic effect period, is variable and changing upon patient to patient. Although the effect of botulinum toxin is temporary, we sometimes obtain a permanent decrease of the deviation. And how this permanent decrease occurs? So there are a number of mechanisms which are supposed to be responsible for the permanent effect of botulinum toxin. The first one is the change in sarcomere number. This was demonstrated by Alan Scott. Sarcomere number increases in elongated muscles and decreases in shortened muscles. And there happens some immunohistochemical changes, and the central adaptive mechanism is very important. That means the control of binocular vision, and traction suture-like effect is also considered to be responsible, that we will talk in a couple of minutes. So if we move through the injection techniques, the golden standard injection technique is to inject this agent with EMG control. And the injection with monopolar needle electrode is performed with the when the EMG signal is maximum. And it can also be used without the control of EMG. And for this technique, Mendoza forceps is used and the muscle is grasped. And the disadvantage for this technique is, with this technique, the injection is on the more anterior side, and in recessed muscles, it is very difficult to reach to the muscle tissue. It is more convenient for medial rectus injections. In our clinic, we use the EMG control injections, and we only use this technique in infants. And some authors propose that it can be used with staptenon injection, but it is very imprecise. Injection under direct view, of course, is very precise, but it is totally against the non-invasive nature of this treatment, so it's a good choice if the toxin injection is performed during surgery. So in childhood, strabismus anesthesia is required, and ketamine anesthesia is the best choice, as it doesn't alter the EMG signals, and recurrent injections are obviously trouble, and ptosis and vertical deviations may be embryogenic. So as a general aspect, botulinum toxin is more effective in mild to moderate angles. As a statistical analysis, it provides 60% of the deviation, but this is not a very meaningful number. And it is most commonly injected in medial lateral and inferior rectus muscles, but there is no real dose-response relation. And when the doses increases, the complications increase rather than the effect of the agent. So it can be said that we have an all or none effect with botulinum toxin treatment. So the main advantage is that it's a non-invasive method, it's easy to applicate, it doesn't leave any scar tissue, repeat injection is possible, and does not alter the chance for further surgery. We all know that surgery cannot be considered in unstable deviations and the postoperative diplopia risk. And botulinum toxin can be used in both of these conditions. And the temporary effect of botulinum toxin is an advantage for some certain motility disorders. So because of this temporary effect, it can be used in acute stage of paralytic, restrictive, and some unstable concomitant deviations, and it can also be used for diagnostic purposes. So how do we use as a diagnostic agent? The first one is to assess the potential function of the paretic muscle, second one for assessment of the postoperative diplopia risk, and the third one is the central fusion disruption. So how do we evaluate the function of the paretic muscle? When there's a paresis in the extraocular muscle, sometimes some recovery occurs, but the contracture of the antagonist may not allow the eye to move towards the functional area of the paretic muscle. So when toxin is injected into the antagonist muscle, if the eye moves towards the functional area of the paretic muscle, that shows that there is some function in this muscle. As you can see in this lady with the 6th nerve palsy, this is you see the limitation of abduction here, and after toxin injection, the abduction increases. That shows that this lateral rectus has some function. So the second area of use of toxin is for assessment of the postoperative diplopia risk. You all know that when we do this test with prisms, the results may not always be reliable, and some patients may report diplopia, but they may overcome this diplopia when their eyes are really corrected. So how shall we know this? So botulinum toxin allows a temporary orthophoric period to assess the postoperative diplopia risk. And we know that fusion ability may be lost in adults, which is called as central fusion disruption, acquired loss of fusion, and an intractable diplopia develops in those patients. And this long-term binocular sensory deprivation related to cataract or uncorrected aphakia that lasted over 2 years, intracranial problems affecting midbrain area is also responsible for this difficult problem. And most of these patients have accompanying strabismus. So in order to offer any solution, the things to do is, first of all, to eliminate all the obstacles that interferes with fusion. So this is first restoration of vision, and then the options to eliminate the effect of malalignment are prism surgery and botulinum toxin. Why prisms are not so perfect for this purpose? Because we know that prisms cause a decrease in visual acuity. It interferes with contrast sensitivity, and this effect is more with Fresnels, and this effect increases with the power of prisms. So this may stop the patient to regain fusion. So if these patients are corrected by surgery, if they cannot be able to fuse the two images, their symptoms may increase, because too far images is much better than too close images that never comes a single image. So we reported recently a group of patients with this difficult and rare problem. Our series included 22 patients, and 13 of them had intracranial problems. 9 patients had traumatic cataract or uncorrected aphakia, and the inclusion criteria was persistent diplopia despite neutralization of the deviation by prisms or synoptophore. And they all had long-term follow-up. And depending on the deviation, the muscles are injected. And in 64% of them, elimination of diplopia was achieved during toxin effect. And in 36% of them, diplopia persisted. And in this group, 3 patients preferred to have botulinum toxin as a maintenance treatment. This is one of our cases. This lady has an hypotropia, you see here, and toxin is injected into the inferior rectus muscle. Despite the orthophoric period that she had with the toxin injection, she could not overcome diplopia. And this lady has a third nerve palsy, had 2 previous operations in another institution, but you can see here that on a horizontal plane, she only had this exotropia. And she had intractable diplopia, so toxin was injected into the left lateral rectus muscle. And you see just 3 weeks later, she started to fuse. And if you go back to the other slide, you see the limitation of adduction here. And just in 3 weeks' time, this is a chronic case, you can see the increase of the adduction here in this patient. So with this abnormal head posture, she could be able to fuse. So compared to previous reports, our success rate was higher, but all the previous reports include very small number of cases, as this is a rare condition. So our conclusions was, botulinum toxin allows the assessment of the potential for fusion, provides optimal circumstances for regain of fusion, and in some cases, a cure can be obtained without any further treatment method, and toxin should be the first-line option in patients with intractable diplopia. So after a breath, let's move to the therapeutic use of botulinum toxin. In order to treat the patients, well, toxin can be used as the only agent, or it can be used as an adjunct to surgery in order to augment the effect of recession, to decrease the anterior segment ischemia risk by toxin injection in one muscle and then transposition surgery, and also to rescue surgical failures and to treat some complications. In concomitant strabismus, there's a long list of its use. It starts with multiple previous surgery, residual consecutive deviations, intermittent deviations, convergence insufficiency, convergence spasm, small angle deviations, sensory deviations, acute comitant esotropia, cyclic deviations, deviations with neurological impairment, and infantile esotropia. I'm not going to talk about all of those, but just as a brief idea, from the Moorfields group, there's a very large series that was reported that in this group, the authors identified 2 main groups. The first group is group 1, are the ones who had long-term benefit with 1 or few injections. And group 2 are the patients who require regular injections, and among this, in between these two groups, binocular vision is the predictor and the locking mechanism for long-term ocular alignment. And when the authors looked for the patient characteristics in the regular injection group, in this group the patients have no binocular function, residual consecutive deviations are common. However, in time, the interval of the injections increase and the angle of deviation decrease in time, but this is a subtle change. So considering the 6,317 patients, only 57 patients required regular injections, and the mean number of injections are 34, and they even had a 68 number of injections. In our clinics, our highest number is 36. And in this group, the patient characteristics are the one with poor binocular potential, complicated strabismus, multiple previous surgery, and they had no adverse effects in long term. Well, I'd like to demonstrate a nice example. Let's say this girl came, well, she's a 17-year-old girl, had no problems in previous life, and after excessive cell phone use, she came with this acute comitant esotropia and double vision. So just one shot of toxin was injected into the left medial rectus muscle, and the results were totally stable. She did not receive any further treatment. So if you look at the childhood use of botulinum toxin, overall, the results are similar with adults. And in previous series, there are a number of favoring results where favorable results are reported. And Rosario Gomez de Liano reported that its effect is comparable with surgery in angles less than 25 prism diopters. And in previous years, we looked for a group of patients for childhood strabismus. We found that in exotropia, it was more efficient. In our group, the results was like that. And we concluded that the best results were obtained in small angle deviations, and those with binocularity achieved long-term stable results. But it is also an appropriate choice where there is no potential for binocular vision, but have some small to moderate angles who are prone to develop consecutive deviations if they have surgery. And the embryogenic factors is not very high, 24% of ptosis, and 9% of vertical deviations in our series, and none of the patients developed serious ptosis, and it was all temporary. Infantile esotropia is another area for the use of botulinum toxin, and in previous reports, and there's a very large series from Rosario Gomez de Liano, and then afterwards there are some other series as well. And the authors reported that the results are comparable with surgery. And one of those series is from Turkey, and they made a randomized controlled trial. It is comparable with surgery. And Emilio Campos reported that if the injection is done before 7 months of age, it is more effective. And in another large series, for over 400 patients, the authors reported that botulinum toxin has the same effect with surgery in deviations below 30 prism diopters, but surgery is more successful in larger angles. There are some conditions that surgery is not the best choice. Well, this is one of those patients. This patient has a microphthalmia, had very large angle, as you see here, very prominent epicanthal folds, and had some anterior segment abnormalities, and I don't want to touch this eye with surgery. So what I could do, this child can only see these epicanthal folds. So what we did was bimedial toxin injections, and he received in total 3 injections, and this is post-injection 7th year, and he had useful vision. So nothing else is performed for this child. Cerebral palsy is another important indication group for the use of botulinum toxin. Well, this girl had no eye contact with parents and very unstable deviation. The deviation is large, and she received bimedial injection, and this is post-injection first week. This is the overcorrected period, and this is post-injection 12 months, and she's making good eye contact with the parents. Cyclic esotropia, which is a very mysterious condition, very rare, and this child had a cyclic ESA deviation. This is the orthophoric day, and this is the squinting day. On squinting day, nothing changed with the glasses. So she received bimedial toxin injections. This is post-toxin 2 months. In 2 months, she was okay. And then afterwards, she started to squint again. And then we prescribed bifocals to her. And after bifocals, everything was very stable. And it's been now 6 years. Now she's at this stage of weaning of the bifocals. So botulinum toxin can break the cycle in cyclic esotropia. Intermittent exotropia is another area where successful reports were done in childhood exotropia, and the results are comparable with surgery again. So botulinum toxin is another indication can be used for augment the effect of recession. Previously, we reported a group of patients that consisted of 10 patients with large angle ESO or exo deviation, and toxin was injected into the recessed muscle during surgery. If you look at the angles, you can see that it is very large angles, over 70 prism diopters, and the postoperative stage, in long term, we achieved successful results in those patients. So this is one of those patients. This gentleman has a large angle exo deviation. This you can see, this is the post-op first week. You see the limitation of abduction here. And this is postoperative 8 months, and the results are stable. So in such a patient, without performing 3-muscle surgery or without performing supramaximal surgery, it is possible to obtain successful results. So recently, we reported another group with sensory deviations that with conventional amounts of surgery plus botulinum toxin into the recessed muscle, because we know that supramaximal surgery has a significant risk of consecutive deviations in this patient group. So our conclusion was that it was a good choice in sensory deviations, and without the risk of operating the good eye and without the risk of overcorrections. Well, actually, we cannot say without the risk, but actually with less risk of postoperative complications. So how botulinum toxin works in these patients? Well, the suggested mechanism is, of course, there are some chains and sarcomeres and so on, but the main thing is the early overcorrected period in those patients, which we call as traction suture effect or pharmacological traction. So during the relative contracture of the antagonist, the relative contracture increases as in the recessed muscle, we also use botulinum toxin because there's a larger relaxation, and the soft tissue healing occurs during the overcorrected period. And Luder and associates reported successful results with this type of surgery in infantile esotropia, and they reported that the consecutive exotropia rate was lower compared to the other series with supramaximal bimedial recessions. So, after a breath with Dr. von Norden's lecture in Ephesus, let's move to the use of botulinum toxin in paralytic strabismus, which is the main area actually. And it can be used in 3rd, 4th, and 6th cranial nerve palsies, and 6th nerve palsy is the most commonly used indication for botulinum toxin treatment, and it is also a convenient agent for supranuclear deviations as well as chronic progressive external ophthalmoplegia. In acute phase, it provides rapid symptomatic relief. In 6th nerve palsy, randomized controlled trials demonstrated that there is no effect on spontaneous recovery. In chronic phase, toxin may be used as the only agent in small angle deviations, can be used toxin plus recession or toxin plus transposition to reduce the risk of anterior segment ischemia. So the use of botulinum toxin in this group of patients is increase the quality of life actually, because let's consider this patient. This is an 18-year-old boy, had traumatic bilateral 6th nerve palsy. He rejects to go out, he rejects to go to school because of the squinting eye. So toxin was injected into both medial rectus muscles. You can see just first 1 week later, you see the increase of the abduction. There's some slight ptosis, but this boy is back to life in just 1 week. And this lady, this is an old lady, has a malignant tumor, has no chance to go on then with surgery and so on. But when you do the injection, there is no improvement in the abduction in this lady, but the symptoms are less, so the patient can be more symptom-free with just one shot of toxin. In pediatric age group, the use of botulinum toxin has also some different aspects, because our aim in children is to prevent loss of binocularity and to stop the development of suppression and also to allow amblyopia treatment in large angles. So let's have a look at this boy. There is a 6-nerve palsy. This is the acute stage in the right side. You can see that this right eye cannot move to the midline. So, but we want to patch this child. So when patching is done, it's not possible for this boy to see because the eye is right there. So the parents are unable to do that. So when toxin is injected into this medial rectus muscle, it is possible to patch this child successfully. And this is an important area of use of botulinum toxin in children. And this is a multiple neurological cranial nerve palsy with 4th nerve, 6th nerve, and 5 and 7. And you see there's a very large deviation here. So toxin was injected into the right medial rectus muscle. You see the limitation of abduction here. And despite the angle of deviation is very large, with just one toxin injection, it is possible to obtain orthophoria. You see there is no increase on abduction. So at this stage, she underwent augmented transposition. And this is the overcorrected period because and this is required in the early period, and then this is 1 year after surgery. So in chronic phase, toxin can be curative in small angles, and some patients may prefer to go on regular injections in this group. And if the result is insufficient, then we may obtain how to plan the further treatment. Well, the problem is, when we do it in combination with transposition, sometimes the overcorrected period may last more than you expected. Well, in this child, you see that there's a 6th nerve palsy in the left side. The eye cannot move. And after toxin injection and augmented transposition, this is the overcorrected period. Okay, this is nice, what we want to see. Well, this is postoperative first week. But this is postoperative 9 months. This child is still overcorrected, and I was thinking that I need to operate once more to take out the augmentation sutures, but then the patient disappeared and come back 2 years later. When she came back 2 years later, I don't know at what period this occurred, but she's doing quite well, she's orthophoric, and the result is quite satisfactory. In 4th nerve palsy, in acute stage, botulinum toxin is not so commonly used, but some authors reported successful results with inferior oblique injections. We are not successful in doing that. In our hands, it doesn't work so well. And contralateral inferior rectus injection may be helpful for symptomatic relief, and in chronic phase, it can be helpful for overcorrections. An ipsilateral inferior rectus injection may be useful to rescue overcorrections related to superior rectus recession. An ipsilateral superior rectus injection may be used to augment the inferior oblique weakening. Well, this lady has a left 4th nerve palsy with a large vertical deviation. She underwent inferior oblique disinsertion plus superior rectus recession. And the recession was done on adjustables. After adjustable surgery, she was doing very good. But then you see this angle here, and 1 month later, she came with this overcorrection with 18 prism diopters of hypotropia with some limitation of elevation. So at this stage, what we could consider is to elevate this eye by injecting toxin into the left inferior rectus muscle. You see the toxin effect here. And the eyes are orthophoric, and she receives just one toxin injection, and this is 4 years after surgery, and the results were permanent, so it worked quite well. And recently, we reported a small group of patients that because of the risk of overcorrection with superior rectus recession, we prefer to weaken the superior rectus muscle with botulinum toxin injection in combination with inferior oblique disinsertion. And this series included just 3 patients, and they all had superior rectus contracture. The vertical deviations were quite high, and the postoperative long-term results was quite satisfactory. You can see here that this patient has a right superior oblique palsy with a large deviation. This is postoperative first month, and this is 12 months after surgery. So the conclusions was that, well, it is a safe alternative for superior rectus recession, and the patients must be warned about the possibility of ptosis. Third nerve palsy is another area of use of botulinum toxin. It may cause a symptomatic relief depending on the involvement of the eye muscles. Does it have any role to stop the contracture of the antagonist? Well, actually, there are no controlled, randomized controls trials, but considering the importance of orbital fibrosis in these patients, I think it may have some role. And in chronic phase, it may be used for reducing the anterior segment ischemia and to augment the effect of recess surgery. Well, this patient has a left incomplete third nerve palsy. This is a medial rectus palsy. Toxin is injected into the lateral rectus muscle here. There is no improvement on adduction, underwent transposition surgery, and he's doing well. Well, this lady has a complete third nerve palsy, has a large deviation. You can see this right eye cannot move to the midline. And in this patient, I didn't want to use traction sutures because of this defect here. So we performed a recess resect in combination with botulinum toxin injection. So this is the postoperative first day. You see the patient has an overcorrection here with limitation of abduction, and this is 10 days after surgery, and this is 14 months after surgery. As you see here, it worked so well that the patient is still orthophoric. And so in third nerve palsy, we normally prefer to use those traction sutures to keep the eye in an overcorrected period for 6 weeks, which is a very unpleasant time for the patient. So this method was reported as successful in Moorfield's group, and we were using this method. But we saw that toxin may provide the similar effect during this acute period. So supranuclear paralytic strabismus is another area of indication of botulinum toxin. It is efficient both in acute and chronic stage with relief of diplopia and abnormal head posture, and the symptomatic relief, also cure, could be obtained. While this gentleman has a post-traumatic bilateral internuclear ophthalmoplegia, he also had intractable diplopia. He received 4 injections, and after post-toxin 2 years, he started to fuse. And you can see the improvement of the ocular motility, and he started to converge, and nothing else is done. And in chronic term, he obtained a so good result. Well, this lady has a right conjugated gaze palsy in combination with seesaw nystagmus. But the gaze palsy was so severe that she had this huge abnormal head posture. She's like that with 30 degrees. Very unpleasant situation. But she had some other serious neurological problems, and we could not consider any surgery. So toxin is injected here into the right medial rectus and left lateral rectus muscle. And this is before toxin injection, and this is the only movement that this lady can do. And this is post-toxin appearance. This abnormal head posture disappeared, and this patient is much more symptom-free after toxin injection. So it can be helpful in such difficult cases. So if we skip to the restrictive strabismus, the indications are Duane syndrome, thyroid eye disease, orbital myositis, Adherence syndrome, post-op restrictions, post-retinal detachment surgery, strabismus. However, the key point here is botulinum toxin does not work after fully developed fibrotic changes. In Duane syndrome, we know that in some patients, the fibrotic changes may increase in time. And toxin may be helpful if we have the patient at that stage. And Rosario Gomez de Liano reported successful results in young age group, in a group of 8 patients with 50% of success. And the Moorfields group reported that 83 of a combined group with adults and children, they obtain a long-term benefit with toxin injection in Duane syndrome. And in those patients, in adults, it can also be used as a diagnostic agent. If you look at this patient, and this boy has a bilateral Duane syndrome, and there's a large ESA deviation, and he received bimedial toxin injections, and this is post-toxin 12 months. The results are till now stable. And this gentleman has a thyroid eye disease. This is the acute inflammatory stage. If we have the patient at that stage, toxin can work, and this is the result of medial rectus botulinum toxin injection into the right medial rectus muscle. Post-traumatic cases is another important group that botulinum toxin may be helpful, and in those with extraocular muscle damage, with anterior segment ischemia, and post-traumatic adherence problems, strabismus related to orbital injury, and these patients may obtain some relief of problems in acute and chronic phase. So let me demonstrate a case example. I've demonstrated this case in previous meetings. This is a ram horn injury. Well, this gentleman has a supraoblique muscle laceration at the retrotrochlear region and also suprarectus muscle laceration. And you see here, I'm sorry I cannot show on the other side, this is the supraoblique muscle with the fiber tissue here. It was not possible to reach the posterior, and suprarectus muscle was also gone. So this is what we see on the next day. There's a large hypotropia. We have no suprarectus muscle, and there is also a limitation of abduction here. So obviously, this patient has adherence problems also, and this hypotropia is going to increase because we have nothing on the suprarectus muscle. So what we could consider, we cannot do any transposition surgery. There's limitation of abduction there. So what we could consider is to elevate this eye and to inject toxin into the right inferior rectus muscle. This is 1 week after toxin injection. This is the toxin effect here. And after 6 weeks, he received 1 shot of toxin again, and with augmented transposition surgery, and this is the result. So luckily, the abduction improved in time, so this is why we could do transposition surgery with vessel sparing technique. So in this patient, in the first injection, reduced the unopposed contracture of the antagonist of the lost muscle, and the second injection was to reduce the risk of anterior segment ischemia in combination with transposition surgery. Toxin can be also helpful to rescue surgical failures for postoperative fine-tunings. It is reported that it is more helpful if it is performed early during the first 3 months. And it can also be helpful in adherence syndrome and lost muscle if performed during the acute phase. When toxin is injected into over or under correction, in the acute phase, it mostly affects through the soft tissue healing and mechanical contractile forces. In chronic phase, it mostly affects through the improvement in binocular vision. Well, this child has a Parino syndrome, cerebral palsy, and the ESA deviation, had this abnormal head posture. So we performed a transposition procedure on both sides with a small recess resect. But on the postoperative first day, what we see was this awful overcorrection. I thought that the medial rectus is slipped, so I reoperated her. I found that everything was in normal place. So, but the forced action test was +4 positive. So we neutralized the lateral rectus resection, recessed it, and this is the postoperative appearance. So there was just slight improvement. So obviously, there was some abnormal muscle contractility in this case, which can happen in cerebral palsy cases, as in skeletal muscles. So she received toxin injection, and this is what we achieved, and this is a permanent result. So the effect was on mechanical contractile forces. This gentleman has a lost medial rectus muscle. The muscle was found reattached, but after surgery, he still had this residual deviation. He had 2 traumatic surgeries, still had the deviation. What could we do? So toxin was injected into the left lateral rectus muscle, and despite this is a sensory deviation, the results was stable for this patient. Adherence syndrome is another nightmare problem, and toxin injection into the inferior rectus during acute phase may provide orthophoria. And this patient has a right superoblique palsy with a large deviation, underwent inferior oblique disinsertion plus suprarectus adjustable recession. During inferior oblique muscle surgery, some tiny fat tissue cells was observed, but after adjustment, he was doing fine. But then he had a vomiting attack with food poisoning, and then he came back like this, with this large hypotropia, and orbital fat tissue was recognized under conjunctiva. Any operation at this stage will make the patient worse. So what I could consider is to elevate this eye with inferior rectus toxin injection. This is post-injection first week. There's an underaction of the inferior rectus muscle, and this is 2 months after injection. So this patient is stabilized in this position. So the effect is again like a traction suture. What was the mechanism? The prolapsus of orbital fat tissue produces an inflammatory reaction, and this reaction pulls the eye. When the eye is kept in primary position during this reaction, then we can have successful results. And sometimes both adherence syndrome, 2 nightmares, adherence syndrome and lost muscle may occur all together. This is a patient referred to our clinic because of the lost muscle and lost left lateral rectus muscle, and I didn't want to operate her at this stage. There was orbital fat tissue under conjunctiva, received very traumatic surgery, but I wanted to keep the eye in primary position during this waiting period. Toxin was injected into the medial rectus muscle here, and this is 1 week after injection, and 6 weeks later, and the lateral rectus muscle was found in orbital fat tissue, and the lateral rectus was reattached with some recession, and this is 1 month after second surgery. So the mechanism here is when there's a lost muscle, most of the time, the surrounding soft tissues reattach to the globe. But if the eye is kept in primary position, these attachments occur on a more anterior point. So toxin provides this effect in lost muscle other than stopping the contracture of the antagonist. So if we move to the complications, the most frequent complication is ptosis, and the rate is quite variable among studies, and recently in a report, some authors proposed that if it is injected with sodium hyaluronate, this may reduce, I don't know, the effect of this. And tonic pupil may be more than expected in a recent report from pedic studies. The most serious complication is scleral perforation and intravitreal injection. In an experimental study from Turkey, it was demonstrated that it is non-toxic to the retina, but of course it's a very serious complication. So what are the problems? First, the problems to reach the target tissue, the uncertainty of the early postoperative period, the inefficiency of botulinum toxin in cases with established fibrosis, the possibility of repeat injections, off-label use in children, cost insurance problems varying upon the region, and lack of grading the dose response. As a personal observation, are those problems is enough excuse for not to use and non-invasive treatment agents for our patients? I think it's not enough excuse. So in all other fields of medicine, if there is a non-invasive treatment possibility, that may cure the patient before surgery, it is always the first option. But in ophthalmology, in strabismology, most strabismologists prefer to go directly on surgery. So it's not because that we like to cut the muscles so much, but it is mostly because of the problems that I've listed in the slide. So if we conclude, among all these, when botulinum toxin is my first choice application, my first line treatment offer. The first one is acute stage of paralytic and restrictive strabismus, early stage of over and under corrections, early stage of adherence syndrome, early stage of lost muscle, intractable diplopia risk with central fusion disruption, the necessity of weakening a rectus muscle in presence of the risk of anterior segment ischemia, recurrent deviations despite multiple previous surgery, and cyclic deviations. It seems that if toxin will disappear for any reason, I will be in great trouble. Well, this is a long list, as you can see here. So the take-home message is, if we summarize the indication categories, yes, botulinum toxin is an alternative to surgery and prisms, as it is mentioned in many textbooks. But it is also a necessary plus agent for the success of surgery. It is a good choice in surgical failures, and it is the only choice if surgery is not an option for any reason. So if we come back to the answer of the question at the beginning, is it just an alternative or more? Are there any plus indications where surgery is not the alternative or is not enough? The answer is yes. Botulinum toxin treatment in previous years created its own indications other than surgery, and it has an additional role in management of challenging motility problems. I'd like to thank you all, and I'd like to remind you that the next meeting of International Strabismological Association is going to be a joint meeting with APOS in March 18 to 22nd in Washington, D.C., and the abstract deadline is very close, 22nd of December. So I hope you'll prepare your abstracts as soon as this wonderful meeting ends. Thank you very much for your attention.
The original comes framed, and it's in Tom Slover's home, but then you already have.
Okay.
Yeah.
Okay. Thank you. Thank you so much.
Thank you.